Dr. Patino here at the Cosmetic Surgery. We're going to do micro-air power-assisted liposuction. You see that tip vibrating. This is my favorite tool to do liposuction, and this will give you much better fat absorption, less fatigue on the surgeon side, and a very non-traumatic aspiration. So there's many things that go into having a bloodless, oil-less aspirate, because we're going to do a fat graft into the buttocks today. And so if you put blood into the buttocks, if you put oil into the buttocks, the body is going to reject the oil and create an oil cyst, and it's going to reject that blood that doesn't belong there. The blood belongs inside the blood vessels. So when it's outside, the body can reject it, form a cannulus around it, similar to what it would do if there's a bullet fragment or a piece of glass that doesn't belong there. The body detects it as a foreign object and starts pushing it out to the surface. That, I contend, is probably one of the mechanisms of action as to how these blowout fractures happen, how these oil cysts happen on the buttocks. So look at these aspirates, please. Focus on how bloodless and how oilless is this fat graft. This is what's going to go into her buttocks as a graft. This is the aspirate, we call it. And normally when surgeons do these, there is blood that comes out. It looks red, and focus on that so you see that there is not even a secret. Well, how do you do this, right? So it is a combination of things. It's like doing a soup. It's not just one thing, right? You may tell somebody, hey, this is how I do my soup, or they may see it but they may not do it the same, right? The fact that you have this micro power-assisted liposuction tool, which is phenomenal, doesn't mean that you know how to use it. This is like a toothbrush, an electric toothbrush, if you would, right? So, but you don't have to be jamming that toothbrush back and forth, because there is going to be bleeding, right? So you just let the instrument do its work, and notice how my strokes are much slower than the average surgeon. So it's similar to you getting the brand new electric toothbrush and going at it as if it was an old toothbrush. Well, there is going to be gum bleeding, and the same is here. So probably one of the most important things is the surgeon, right? If the surgeon is in a rush and he's jamming that instrument back and forth and he's using these huge cannulas, yes, the procedure will be done faster, but there will be bleeding. And that usually the surgeons, what they do is they do a processing, fat graft processing, so to clean up all the blood, to clean up all the oil. But guess what? That takes time, right? So we go slower, but we don't have to process that fat in any way. The only thing we do is we collect it in normal saline, and that's about it. But what can the patient do? So we ask the patient not to take any aspirin-like medications, no ibuprofen, no herbs, no vitamins of any kind for 2 weeks before and 2 weeks after the procedure. What does the surgeon do? The surgeon does not ask the patient to take any aspirin-like medications, vitamins, herbs, or supplements. Some surgeons routinely tell the patients to take Motrin, right? Ibuprofen and herbs and vitamins and that sort of thing. The surgeon doesn't give any blood thinners, so we don't give any aspirin or aspirin-like medications, no heparin, no enoxaparin. Some surgeons routinely give you these medications to prevent a blood clot. And it's not like we're not concerned about blood clot. A blood clot is the thing that can kill you, and we never had anybody die, thanks to God, from any procedure, from any cosmetic procedure that we ever done here at the Cosmetic Surgical Center of Rosarito. But the key to preventing a blood clot is not enoxaparin, it's not aspirin, it's not heparin. The key is early ambulation, and we have probably one of the lowest incidents that I've ever seen for thromboembolism, right? And we never had anybody die. But I don't give aspirin-like medications or enoxaparin. And probably the most important thing is patient selection. No, I'm not going to operate on you if you already had a blood clot. No, I'm not going to operate on you if you had a heart attack already. No, I'm not going to operate on you if you have a condition that predisposes you to a blood clot. So, you know, I'm a board-certified internist, so we choose our patients right and to minimize the risk, right? Look, that's incredible. It's incredible what we do here. So I'll talk to you a little later about the fat grafting. Thank you. All right, so these very, very bloodless, oilless, yellow, pure fat that we obtain here is what's going to go into her buttocks. So when you're watching surgery and you watch surgeons do these procedures, notice what goes into the buttocks, right? If what you're seeing is red, well, that means that there is fat and blood, right? Obviously, right? And of course, your butt is going to look big and gorgeous at the beginning, but then it's going to go down as that blood gets reabsorbed, right? And if there is oil in there, guess what? You may get an oil cyst, right? So normally when you do fat grafting, you lose about 30 to 50% of whatever the surgeon puts in there. So normally the surgeon overcorrects. In other words, they put more knowing that it's going to shrink with time. Plus, you know, the swelling and that sort of thing. But our patients retain all of the fat graft very much. Why? Because it's pure. It doesn't have blood. It doesn't have oil. It's pure fat graft. It is absolutely gorgeous. So that's how we do it here at the Cosmetic Surgical Center of Costa Rica, and there's many things that go into it. But I can tell you one of the most important and most difficult things is I teach other doctors how to do these, but the most important thing is the surgeon. How the surgeon does this slowly and takes his time. The tumescent anesthesia to mess all the areas properly, right? And we take our time and we wait a long time. You know, usually waiting is important, and that's one thing that the surgeons usually cannot do, because if you're doing, you know, 2 or 3 or 4, some surgeons do up to 10 cases per day. Well, you know, you're gonna have to go pretty fast, you know. And this is like driving an automobile, right, on the freeway. See, my speed, I would say, is about 45 miles per hour, right? So I have much less risk of crashing. Of course, there could be a big truck that comes and crashes me. It's possible. So, you know, we have risk, but the average surgeon, I think, drives about 75 miles an hour, right? So a little more risk, right? But there is some surgeons that drive at 260 miles an hour, right? So, and those are professional drivers, and usually, you know, everything goes well, but if you crash, that's usually lethal, you know? So more risk, more complications, the faster you go, right? If you do in many cases, more risk. It's like driving a car. And sometimes, you know, you go on the freeway and you see this guy that crosses you at full speed, right? And then there's traffic up front, and you see him slow down. And then you get onto a traffic light and you see him waiting at a red light. The guy that just passed you, right? So look at this. Look at this golden aspirate.
Wow.
We have an anesthesia provider here that's shadowing Dan, right, Dan?
That's right. There's Louis.
Yeah.
Wow.
And have you seen liposuction before?
Not like this.
Not like this.
Not like
Well,
this.
explain.
Well, there's like no blood.
This is another advantage of going slow is that, you know, you're not going to perforate any internal organs, right? So when an internal organ injury happens, it usually happens to a very tired surgeon that's working probably on a Friday night at full speed, probably hungry, probably sleep deprived, probably just wishing to just go home and rest, right? And they lose what we call situational awareness. And they go into an unintended area, and then you have internal injury, you know, like organ perforation, either in the abdomen or in the chest, something that has never happened to us. But I believe it's because of this technique of going slow, right? Taking your time and being relaxed. It's also easier for the anesthesia providers and for the entire staff, right? You don't have to be turning over a whole bunch of patients. It gets chaotic. It's just difficult, stressful for everybody. So we want to keep it, you know, nice and stress-free environment here at the Cosmetic Surgical Center of El Cerrito. It's also good for the surgeon. You know why? Because you're not sweating the procedure. You're not stressed out. In addition to that, you know, most surgeons are ambidextrous, and I am ambidextrous. So what happens is that we switch. You'll see me go to my other non-dominant arm, right? So, and so we limit also injuries on the surgeon, occupational injuries, right? We limit wrists, and we limit elbow, and we limit shoulder tendinitis and injuries that result from repetitive motion, right? If you go real... Righty, so what color do you see there, huh?
Yellow.
Man, yellow, beautiful fire. Isn't it incredible, huh?
So incredible.
Yeah. It's unbelievable, man. And so it gives me pleasure. It's like I get marvel at how the airplanes fly, you know. and this to me, even though you can see airplanes fly every day, I still marvel at it, right? But here's the same. We see this pod all the time, and I still marvel at it, and I admire it, and I see the image of God here. Thank you. Okay, so you guys, this is, I mean, we're basically done with this other side, and notice the complete absence of bleeding. This is just a unique technique. It is predictable, so don't think that we're just showing you the best cases. We show you whatever the patient consents to show, we show, right? But there is many cases that you can see how this is a bloodless technique. This is also incredible for the patient because she's going to have less bleeding, less bruising, less anemia, and a much faster recovery, right? Our patients usually are full of energy the next day because they don't have anemia, they can walk, they don't have pain, they can walk, and when they walk, they prevent the most lethal complication, which is that of a blood clot. And we want to keep it that way. And we're doing high definition liposculpture. I'll show you photos of the lines of how beautiful she looks. She doesn't want to show any before photos, so we're not going to show before photos, but we will show the intraoperative photos here when we show you, when we make the lines, you'll see. But notice my strokes are so slow. I'm also very comfortable, so we avoid injury to the surgeon. Thank you. So look at the high definition. This is incredible, right? And we're basically done with this procedure. We're finishing up. We're going to take some photos. But what I want you to see is look at the aspirate. Look at the aspirate over here. Look at that. Look what's coming out. It's incredible, right? So it's yellow, beautiful fat, right? It's just incredible. Look at that. Toward the end of the procedure, we're going to show photos. But once you let me show you. Look at this. See? We're down to, this is the pinch test. Here, hold on 1 second. This is the pinch test. Look at that. We're down to nothing on the pinch test. Look at that. Incredible. And we're still getting incredible amount of beautiful yellow fat here at the Cosmetic Surgical Center for Fredo. Concentrate on this yellow fat again, please. show that even down to the end of the procedure, because we're basically done, we still have very, very nice, beautiful yellow parts. That's incredible. It's almost gold. Look at that.
Wow.
Yeah,
Incredible.
very nice, very nice. So we're at the end of the procedure, you guys. But I continue with my slow strokes. This is just incredible. Thank you. Her buttocks are over here. So the secret of doing a buttock augmentation, we haven't touched our buttocks, is, you know, caving in here so that the buttocks pop up, you know. And so this is the pinch test. So we're down to 0.5 centimeters here. You saw the abdomen, basically the same thing. So everywhere we go, look at this, see? Very nice. So she has a nice waist. And now we're gonna turn it to the other side. So she's on the lateral decurus, we call it. She's on her side buttocks over here. This is her waist and her back. Thank you. All right, so we're doing ultrasound guided gluteal fat transfer. Like I told you, look at the quality of that fat graft. It's incredible. So I'm looking at the ultrasound, I'm looking at the patient, and I'm looking at that bloodless, oil-less fat graft. And we're doing it under ultrasound guidance to make sure that we go in the deep subcutaneous space where we're supposed to put the fat graft safely. This is according to the World Association of Gluteal Surgeons guidelines. But the important thing that I wanted to show here is this fat graft that's completely, once you do a real good close-up on that fat graft, so you can see that there is no blood, you can see that there is no oil at all, and that's because we obtain it in atraumatic fashion, right? And many things that go into it we already talked about.
100.
Thank you. Alrighty, so again, look at the completely bloodless and oil-less fat graft. And this fat graft has not been treated in any way other than we collected it in 500 ml of saline, right? Actually, 1,000 ml saline in this case, right? But that's incredible, right? She looks incredible. And so I'm looking at ultrasound, so we can do these.
100.
And I put 100 at a time, right? So we can do this in a very controlled fashion. So I do 100 there and 100 there. And now we're gonna move to the intergluteal incision. Thank you.
All right, so we're doing ultrasound guided gluteal fat transfer. This is the patient's skin. Over here is the superficial gluteal fascia. Underneath it, with really very little space, is the deep gluteal fascia, and this is the striated muscle. Dr. Patino's cannula is right in between both. It's right here, and we're gonna see him wiggle it. He's gonna deposit some fat.
All right.
So see how we have this gray? This gray is basically the ultrasound representing the fat that's entering the space that's coming in between the superficial gluteal fascia and the deep gluteal fascia. So that's the fat that Dr. Patino is depositing.
Thank you.
All right, we're doing ultrasound guided gluteal fat transfer. This is the skin. This is the superficial gluteal fascia. This is Dr. Patino's cannula. And then under here we have the deep gluteal fascia.
And so this is the cannula. I'm wiggling it, and I'm gonna give it a bolus. So point to the tip of that cannula, and you're gonna see a gray cloud. That is the fat graft going in. 1, 2, 3.
All right, so we see the gray cloud coming in right here, and you see how everything's kind of jumping up, getting pushed down. Basically, that's the fat coming into the space, and it's basically pushing down on the deep gluteal fascia, and it's pushing up on the superficial gluteal fascia.
Incredible.
See that gray cloud? That's the fat coming in.
Yeah, so that's this deep subcutaneous space. That's what we want.
Between the deep gluteal
fat.
fascia and the superficial gluteal fascia.
Yeah, exactly. I inject as I withdraw. This is just beautiful anatomy. Thank you.